Welcome to the Baptist HealthTalk Doc-to-Doc Podcast, a conversation for physicians by physicians, providing insight on the latest in medical practice, research, technology, and innovation in healthcare. Join Baptist Health experts as they offer practical advice for clinicians covering a wide range of specialties. Cancer, neuroscience, orthopedics, and cardiovascular care are just some of the timely discussions you'll find right here on the Doc-to-Doc Podcast.
Good morning. My name is Michael McDermott. I'm a neurosurgeon and the Chief Medical Executive at Miami Neuroscience Institute.
And my name is Minash Mehta. I'm the Deputy Director at Miami Cancer Institute and Chief of Radiation Oncology.
This morning on the Doc-to-Doc podcast, we're going to be talking about a rare tumor, a primary bone tumor that involves the skull base and the sacrum called chordoma. And I was wondering, to start us off, Dr. Mehta, if you could discuss the incidence and epidemiology of chordoma for us.
Mike, thank you very much for that question. Chordoma is actually a very rare condition. The actual age-adjusted annualized incidence is less than 1 in a million adults in the United States. And therefore, this is a disease where very few people have vast amount of experience given its rarity. It tends to occur slightly more commonly in males compared to females. And there is a racial predilection in the sense that it's very uncommon in the African-American population. It tends to be very, very uncommon under the age of 40 and typically occurs in individuals older than that, although pediatric cases have been reported. And most often, the tumor presents in the skeleton from the skull base down to the sacrum. That's where the vast majority of these patients would develop their tumors. But there are rare cases of extra-axial chordomas reported primarily in the head and neck mucosal regions as well.
Can you talk about the steps in the diagnosis and treatment planning in general for a patient with chordoma, let's say skull-base chordoma?
Right. So skull-base chordomas represent about a third of all chordomas, the other 20% in the mobile spine, and the remaining approximately 40 to 50% in the sacral region. Skull-base chordoma patients will present with symptoms that are relatively non-specific in the sense that they're not specific to chordoma per se, but these are the kinds of symptoms that patients would develop for any kind of a skull-base tumor, whether it's a skull-base meningioma, whether it's a chondrosarcoma. Sometimes patients have headaches. Sometimes they can present with diplopia. Sometimes they can have other cranial nerve palsies. Sometimes if the tumor actually invades through the nasal passages, they can actually have symptoms of nasal congestion. So really, it's any of the cranial nerves at the bottom of the skull base that could potentially be affected, and that is a common presentation for these patients. The presentation is slow and chronic because the tumor is typically slow and chronic in its evolution.
Right, so there is a differential diagnosis based on the radiology of imaging of skull-base lesions, and obviously tissue sampling is important in order to direct the therapy. I just wanted to talk a little bit about the surgical approaches to skull-base chordomas and chondrosarcomas. There's basically been an evolution from the late 90s through the last 20 years where we've used more often an endoscopic endonasal, minimally invasive, if you'd like to call it that, approach using neuronavigation. We are able to superimpose bony and MR details as well as magnetic resonance angiography 2D image sets to depict the position of the internal carotid artery. As you know, most of these arise in the clivus, but can extend laterally. And as you mentioned, the symptomatology is usually related to cranial neuropathy as the nerves exit the skull base across from the foramen magnum up to the optic canal. But we used to use open transcranial approaches with a variety of different corridors, which were, big operations, very morbid. You require more than one surgical approach in order to attempt to get gross total resection. And with the advent of endoscopic endonasal approaches, this has really revolutionized the surgical treatment of skull-base chordomas. Now, in sacral chordomas, the discussion is whether or not you do an intratumoral removal or a marginal resection. And more often in sacral chordomas, the approach is for marginal resection, so wide en bloc, gigantic operations, destabilizing the pelvis, tying off the thecal sac at the bottom, resulting neurologic deficits that might go along with that. Frequently, these cases have to be done with general surgery, plastic surgery, and then spine surgery from either a neurosurgeon or orthopedic surgeon or working together to reconstruct the spine. But in the skull base, it's always an intratumoral resection. And in a review of the literature for all chordomas, there didn't appear to be a significant difference in overall recurrence rates or survivals, whether used marginal or intratumoral resection. And surgery alone is not usually definitive for chordoma. And we can talk about that later. But I think that the advent of endoscopic and nasal approaches, neurosurgeon operating with ENT, head and neck, endoscopically trained surgeons made a big difference. We utilize a nasal septal mucosal flap. We can use it on both sides in order to repair any defects in the basal dura, combining that with lumbar or external ventricular drainage for a period of time post-op.
So, Mike, there have been dramatic advances in neurosurgical techniques, in advanced imaging, in anesthesia technology, and in postoperative recovery processes and procedures. But in spite of all of that, these are very substantial operations with the potential for significant complications. Could you address the issue of what potential complications and how frequently they might be encountered?
Yes, certainly. So when we discuss the surgical approach with a patient, we discuss the risks related to general anesthesia. The operations are usually more than 4 hours in length. So this relates to things like pneumonia, bladder infection, deep venous thrombosis. Intraoperative sudden death is extremely rare related to a cardiac event, usually 1 in 200,000. The specific complication profile related to the surgical approach using endoscopic methods for skull-base chordomas include predominantly things like cerebrospinal fluid leak. Because if the chordoma transgresses the dura, which they frequently will do when the tumors are large, you've got a wide open CSF space that you need to repair. And CSF leak rates post-op, in spite of best methods, can be as high as 34% in the short term. Usually you can, solve the problem with multiple procedures, most commonly CSF diversion. You sometimes have to re-op. We use a combination of autologous fat and nasal septal mucosal flaps. We can harvest fascia lata in order to try and reconstruct the cranial base before applying the vascularized flap. But the biggest risk is that of cerebrospinal fluid leak and the possibility of postoperative meningitis. Now, intraoperative carotid artery injury is also a risk. Thankfully, it's very rare. And as you mentioned, the technology advances have allowed us to superimpose 2D bright red axial round circles representing the position of the internal carotid artery on the axial 2D images. You can represent them in 3D, but it's actually more, it's easier for the surgeon to work with when they're represented on the 2D MR images. So that can help us. We can use intraoperative Doppler to confirm the position of the carotid. You can actually, once you unroof the bone around the carotid artery, you can actually see the carotid pulsating. So it's not a mystery as to what's there. If you get a carotid artery injury intraoperatively, the best method for treatment is actually autologous muscle. And this has been proven in rabbit models. There's actually a surgeon in Australia who offers a course using pigs where they directly injure the carotid and get the surgeon used to the calamity of arterial blood coming out under high pressure and having prepared a small piece of autologous muscle. And that is the thing that actually appears for some reason to work the best. Obviously, if you have that event intraoperatively, the procedure's over. You can always come back, but you've got to look after the patient. You would get the bleeding stopped with either muscle, some sort of tamponade with a Foley balloon catheter, notify interventional radiology, take them straight down. They would do an angiogram. If they see a false aneurysm or active bleeding, obviously they have to sacrifice that carotid. And then there's associated risk of ischemic neurologic deficit related to that. It's amazing that the few times thankfully I've not had it happen to me, but the few times where I've helped out when it's happened, the patients have not suffered an ischemic stroke. And that, of course, is related to the collateral circulation through the circle of Willis. The other risks are that of cranial nerve injury, particularly those nerves in and around the cavernous sinus, third, fourth, fifth, sixth nerves. Sixth nerve appears to be particularly sensitive to manipulation when there's extension into the cavernous sinus. And thankfully, most of the time, those pareses recover over time. The problem really, though, is with recurrence. So if you operate on the patient and you treat them and the tumor comes back, reoperating can be very problematic. And of course, the complication profile related to CSF leak and the like essentially doubles. So it can be, unfortunately, a morbid profile.
So, Mike, as you pointed out, R0 resections are very unlikely in the setting of skull-base chordomas, which implies that almost always there is going to be micro or macroscopic residual disease. Is surgery curative in any subset of patients by itself?
Most surgeons now, thankfully, recognize that surgery alone is not curative for true chordoma. There's a difference between the outcome, as we know, depending on the pathologic subset, different markers that might predict recurrence. But in a skull-base chordoma, the likelihood of getting, quote, complete resection is almost zero because of the bone involvement to the extent you can keep drilling until you get to normal bone. So for skull-base chordomas, most of us would believe that adjuvant therapy is necessary. Maybe you could actually talk now about the different types of radiotherapy that could be considered in the adjuvant setting.
Absolutely. So I think with that recognition that R0 resections are extremely unlikely and the likelihood of relapse is very substantial, there is definitely a place for adjuvant therapy. A number of efforts have been made towards identifying systemic therapeutics that could be effective, but unfortunately, these have largely been unsuccessful. There is one direction that I want to talk about before I go into radiotherapy first, and that is the recognition that the vast majority of these tumors express an aberrant protein from a gene called brachyury. And this can potentially be a target. There are clinical trials of a brachyury vaccine that are currently being tested. And so this shows some early promise, but it is very early and experimental at this point in time. Effectively, what this means is that the standard adjuvant approach after surgery has to be radiotherapeutic in nature. And in fact, radiotherapy as an adjuvant to surgery has been used for decades. There are a number of developments on this front that are worth thinking through and discussing. Historically, the proximity of this tumor to critical normal structures, the pituitary gland, the temporal lobes, the brainstem, major cranial nerves, this has really limited the radiation dose that can be delivered. The other thing to remember and recognize is that tumor cells that are embedded in bone are in a relatively hypoxic environment, and that makes them somewhat radioresistant. Consequently, the conventional radiotherapeutic doses of 50 to 54 gray that are often given for other skull-base tumors, such as meningioma, and work quite well, are generally quite ineffective for chordomas. Data over a period of a few decades have demonstrated that this is one of those tumors where there appears to be a significant benefit from escalating radiation dose. And this, of course, is very difficult to do with conventional therapeutic approaches. As a consequence, chordoma has become one of those tumors that is frequently treated with particle therapy, either proton therapy or in Europe and in Japan with carbon ion therapy. We now have very intriguing data, especially from the Paul Scherrer Institute in Switzerland, that doses in the order of 74 to 78 gray produce some of the best reported 5 and 10 year survival outcomes in patients with chordoma. And in fact, commensurate with these developments, which really represents the developments in surgery, imaging, radiation oncology, there was a very intriguing paper that looked at 5 year survival rates in chordoma as a function of the decade in which the patient was diagnosed. And starting in the 1970s, if one looks at patients in buckets of decades, there is incremental but substantial improvement in 5-year survival rates. So high dose radiotherapy is by default a necessary requirement, often very difficult to do with standard photon approaches, and protons and carbon are actively being used in these patients.
Yeah, what about, my previous place of employment at UCSF, we didn't have the availability of proton therapy, but had a sophisticated photon delivery systems using IMRT techniques such as CyberKnife, and did a dose escalation study looking at toxicity and short-term tumor control. And the results appeared to be, equivalent. We had experience with sending patients to a proton center where there was a very frequent problem with temporal lobe necrosis. So can you talk about how that could happen, using protons, which are supposed to be so selective?
Excellent point. So there is no question that at the end of the day, this is all about dose, not necessarily technique specific, but it's really more to do with dose. If you can safely deposit dose to the intended target and minimize radiation dose to surrounding structures, that's your best bet. And sometimes if you have an excellent resection and you have small volume disease, even stereotactic radiosurgical techniques can be employed for delivering the appropriate dose that's necessary. The CyberKnife is a very good tool for many such patients. So indeed, IMRT techniques, CyberKnife techniques have been employed, and there has never been a randomized trial. But most of these techniques are able to deliver doses in the order of 64, maybe up to 68 gray. But pushing it to 74 to 78 gray becomes very difficult even with these techniques. So what tends to happen, therefore, is an inherent selection bias. So if a patient can receive photon dose escalation at an institution where particle therapy is unavailable, they would be treated at that institution with a dose escalated approach with photons. Patients that have larger volumes of residual disease in much closer proximity to critical organs are then often referred out to other facilities. And these patients often end up in the carbon and proton facilities and are often the larger tumors, the greater residual volume tumors. We do see that in our practice as well. These are much more challenging cases because although protons are selective and diminish the dose beyond the exit beam, there is a small component of distance beyond the exit beam where the Bragg peak radiobiological effectiveness is high enough that one has to worry about where you are stopping the proton beam. If you're stopping the proton beam at the temporal tip, that portion of the temporal lobe can potentially get a biologically higher dose and can be susceptible to radiation necrosis. So this is all a question of identifying a balance between the dose that you want to give and the dose that you can safely give.
Now, even though I'm a neurosurgeon, I'm a frustrated wannabe radiation oncologist because I love the technology. But talk to us about the limitations of beam paths with proton therapy and why that is so. Unlike, for example, a gamma knife with 192 beams, CyberKnife plan that might have up to 140 beam paths, et cetera. Talk to us about the reasons why there's a limitation on beam paths with protons.
So there are a few things about proton therapy that are different than standard photon therapy. For example, if there are air spaces and bone, in other words, tissue with rapidly changing densities in the path of the proton beam, then there's greater uncertainty in the dose deposition from protons. So this is something that needs to be kept in mind at the time of treatment planning and often can be a barrier to robust treatment delivery. There are techniques of robust evaluation and robust planning that can mitigate this, but these are relatively new developments and can only be employed with techniques such as pencil scanning proton therapy. The older techniques, which was passively scattered proton therapy, were much more susceptible to these issues, whereas the newer modalities using Monte Carlo approaches give you much precise radiation dosimetry. Metal is another problem. This is more of an issue for spinal chordomas, where reconstruction is often necessary, and the metal, in fact, stops and absorbs the proton, therefore creating a cold spot just beyond the metal. Often that's exactly where the tumor bed is, and we end up with cold spots within the tumor bed. This can be very challenging for proton therapy. In fact, there are very categorical data that if one looks at the presence or absence of metal, local control rates are significantly different if proton therapy is being used. Now, the issue of beam paths, this is a very intriguing issue. There is a new technology called proton arc therapy that has now been developed and is about to go clinically live in the next 6 to 24 months. We are one of the pioneering institutions for this. This technique will actually allow us to deliver protons from multiple beam directions, very similar to how photon therapy with tomotherapy or CyberKnife or any other rotational technique can deliver. And this will, in fact, provide freedom for multiple degrees of targeting the tumor.
Great. Now, these tumors are, as we mentioned and discussed, decidedly rare compared to, for example, breast cancer, 1 in 15, 1 in 10, chordoma is 1 in a million. How important is a multidisciplinary approach to deciding on treatment for these tumors?
I think this is perhaps the key for success in the management of any patient with chordoma. The rarity of this tumor implies that no one individual can become a superb expert in the management of these patients. And in fact, input from multiple specialists is absolutely critical. This is clearly a situation where a team is critical, a village is what is necessary to take care of these patients. I recommend to all my chordoma patients that it's not always the technique or the technology or a limited expertise that's going to drive the ultimate success, but the presence of an entire team. As an example, relapse is not uncommon in patients with chordoma. And what do we do for relapse? Sometimes we cannot get an adequate dose with radiation. What do we do in that situation? How do we combine our efforts in neurosurgery, in radiation oncology, in neuro-oncology? This all needs to be prospectively thought out. Even more importantly, imaging can be very confusing in these patients. There are treatment-related changes, there are postoperative residual findings, there is the presence of metal artifact. This can all be extremely challenging. And without a very strong radiology team, this becomes complicated and difficult. So clearly, a team is what it takes to achieve success in the management of chordoma patients.
Yeah, I agree. I mean, surgically, they're very frustrating for us because, of course, we can't cure them with a single approach. And as you discussed earlier on about the vaccines against brachyury, certainly some of the trials are also looking at poly-TK inhibitors based on the PGFR and EGFR status. So we're hopeful that some of those adjuvant treatments prove to be successful. I always recommend to my patients they search out the Chordoma Foundation website for advice and support. It's a very good group. I've participated in their seminars and Zoom broadcasts, and I think that's important. The patients need to know that they're not the only one with this tumor as rare as it is. Any closing comments, Manesh?
I just want to add about the need for continuing research and innovation in the management of these patients. We, for example, have been exploring the possible use of immune checkpoint inhibitors in the context of patients where we cannot deliver adequate radiation dose, or in the context of recurrence in combination with re-radiation. And although the data are sparse and anecdotal at best at this point in time, we are seeing some significant responses that have intrigued us to the point of considering developing a clinical trial of combinatorial immune checkpoint inhibition and radiation as an upfront adjuvant after initial resection in these patients. This is something that we are working on. So this, again, is another opportunity for our patients to remind them that the reason you need a team is that the team can bring multiple resources of this nature together and perhaps provide clinical trial opportunities that are worth seeking out.
Yeah, I agree. Well, Dr. Mead, I'd like to thank you for your time this morning. I'd like to thank the audience. I'd like to refer our attendees to the clinicaltrials.gov website, the Chordoma Foundation website for further information, and thanks for your attention this morning.
To find out more about the topics covered on the Doc-to-Doc podcast, please visit physicianresources.baptisthealth.net.